Good evening and welcome to Doctors on Call. I'm Dr. Peter Nalin, professor and head of the Department of Family Medicine and Biobehavioral Health and Associate Dean for Rural Medicine at the University of Minnesota Medical School, Duluth campus. I'm your host for our program tonight on ENT problems, including sleep apnea. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Andrew Davis, an ENT specialist with St. Luke's ENT Associates, Dr. Ryan Harden, a family medicine physician with Gateway Family Health Clinic in Sandstone and a faculty member with the University of Minnesota Medical School Duluth, and Dr. Mark Rhodes, an ENT specialist with Essentia Health. Our medical students answering the phones tonight are Anna Shue from New Ulm, Minnesota, Tanner Nordseth of Round Lake, Minnesota, and Lucas Rodermacher from Battle Lake, Minnesota. And now on to tonight's program on ENT problems, including sleep apnea. And Dr. Harden, the first question is for you. What is sleep apnea?
So sleep apnea, actually what apnea means is the absence of breathing. So sleep apnea is a condition where when somebody's sleeping for short or more prolonged periods of time, they'll actually stop breathing. And when that happens, the brain, it signals to the brain that there's not enough oxygen in their blood, and their brain wakes the person up, they change position, and go back to sleep.
Okay, thank you. And Dr. Rhodes, will having a tonsillectomy cure sleep apnea?
So sleep apnea is called obstructive sleep apnea because something is blocking or obstructing the airway. If your tonsils are big enough, or primarily for children, taking the tonsils out and often including the adenoids, in fact, will often cure sleep apnea. So primarily children. For the adult population, if your tonsils are big enough, they will cure sleep apnea.
Dr. Davis, how about the symptoms of sleep apnea?
Well, it can vary from patient to patient, but usually you see daytime somnolence, so you're tired throughout the day, you can be more irritable, but also you can have attention issues, problems at work. There also could be a significant psychological factor to it as well. But daytime somnolence is the main one.
And Dr. Rhodes, what are some leading surgical procedures to treat sleep apnea?
So as I said, sleep apnea is obstructive, meaning the airway is getting blocked off. And actually I want to mention, before we talk about surgical options, the biggest and best treatment for sleep apnea is actually what's called CPAP, which is continuous positive airway pressure. I tell patients that our number one goal is do no harm as physicians. CPAP is maybe one of the only treatments I know in medicine that really doesn't have any significant side effects to it and works really, really well. So I always recommend to patients they start off with CPAP. As far as surgical options, as surgeons, what we try to do historically is try to remove stuff. Our surgeons are pretty good at cutting things out, so we would cut the tonsils out, sometimes remove part of the palate and the uvula. That was our primary surgical treatment for sleep apnea for many, many years. It works, but not great, and it's pretty painful. More recently, we have something called the hypoglossal nerve stimulator implant. This is something where we attach an electrode to one of the nerves that controls your tongue, and what it does is it tightens up your tongue throughout the night. So that's our newer surgical treatment that's working great for us.
Thank you. Dr. Harden, what can patients expect if they're recommended to have a sleep study?
So we use sleep studies to diagnose sleep apnea. A lot of times patients will come into the clinic with symptoms consistent with sleep apnea, daytime sleepiness, snoring, high blood pressure that's refractory to treatment with medicines. And in order to confirm a diagnosis of sleep apnea, we typically recommend that patients have a sleep study. Sleep studies can be done in the hospital. Also, probably less commonly, sleep studies can be done at home. But when somebody's in the hospital, they're monitored with a video, and their respiratory rate is monitored, their blood oxygenation is monitored, and their heart rate's monitored. And based on a combination of all those parameters and apneic events where patients actually stop breathing, I think more than 5 times an hour, that's consistent with a diagnosis of sleep apnea. So generally speaking, I think the best way to diagnose sleep apnea is an in-hospital sleep study.
Dr. Rhodes, you mentioned obstructive sleep apnea earlier. What about central sleep apnea? A caller from Duluth wants to know, can one outgrow central sleep apnea?
So central sleep apnea refers to sleep disturbance and apnea that's modulated or controlled through the brain. So that's a much different disease than obstructive sleep apnea. And so I'll be honest, I'm going to say I'm a surgeon. I do really well with obstructive sleep apnea. Central sleep apnea, I kind of leave to our sleep colleagues. So I really can't answer that one specifically.
Anything else to add on that one?
Anybody else familiar with
Central sleep apnea?
I think central sleep apnea is primarily neurological in origin, where the brain just loses its ability to tell the body to breathe in a regular pattern. So I would say that it's typically not something that people would outgrow.
Okay.
But can be treated with CPAP.
With CPAP.
Yep.
And can you, for our viewers, just say a little more about what is actually happening when the CPAP apparatus is being worn?
Yeah, so what CPAP does is it forces air into the throat and actually opens up the back of the tongue region, and also wherever the level your obstruction is, or whatever reason why you're having the obstructive event, the air kind of just forces the airway open so you can actually breathe. You can put oxygen to it too if your oxygen is too low throughout the night, but it's just basically a method to force air in.
Thank you. Dr. Rhodes, what is a deviated septum and why might it matter?
So the septum refers to the structure inside your nose. That's basically a wall that divides it into a left side and a right side. So it's supposed to go right down the middle, but majority of us, or almost all of us, do something over our lifetime. We fall off the swing or get hit by a baseball, or we do something to hit our nose, and it pushes that wall off to the side. We refer that to as a deviated septum. So what it tends to do is block one nostril or the other, and depending on the degree of severity, sometimes it's completely occluding that nostril, and so surgery can help fix it, move it back into place.
Dr. Harden, a caller asks, not having a cold or allergies, but what might be leading to a constantly runny nose?
Well, that's a good question, and one I get a lot in the clinic. There's something called vasomotor rhinitis, where for reasons that we don't entirely understand, the nerves in the nose cause the nose to secrete more secretions than we would typically expect, and that can cause kind of a constantly runny or drippy nose. It can also go back down the back of the throat, and that can cause a chronic cough. Typically, as we age, that has a tendency to get a little bit worse, vasomotor rhinitis. There's treatments for it, but...
Medications are the other thing. Certain of our, especially blood pressure medications, can cause a runny nose, drippy nose, or congested nose. So it's the other thing to look at. It's a great one with your primary care provider to review some of your medications sometimes.
For side effects of the current meds. Or
Right.
Dr. Davis, a caller from Two Harbors has had sleep apnea and CPAP use for 40 years with recently started snoring. What might explain that?
A number of things could explain it. It could just be that the mask isn't fitting as well. It could be that you're not getting as good of a seal on the mask. It also could be that you just might need some more pressure from the CPAP itself to kind of keep the airway a little bit more stented open. So I'd advise you to review with your either sleep doctor or your primary doctor about potential reasons why that could be happening. Also, if you had increased weight gain or some other lifestyle changes that could also increase your chance of it. But
A caller asks, why are they more tired after using the CPAP? Anyone want to answer that?
probably because the CPAP's probably not working that great for them. So once again, that's in those type of situations, you want to, whoever prescribed you the CPAP, you'll want to spend some time with them trying to figure out better ways to use it. But if you're feeling more tired after using the CPAP, I would question whether or not the CPAP is being properly used.
Or CPAP is a great treatment, but it can be hard to get used to. And sometimes if it's causing you more annoyance than benefit, it could be that it's keeping you awake more. But there's lots of ways to modify that, multiple different types of masks to help you get more acclimated to your CPAP.
About 50% of people cannot tolerate a CPAP. So it's a very common thing not to be able to tolerate a CPAP, and sometimes it's you need to go through a bunch of different masks before you actually get a good seal.
I'll just add to that, if it's one of the rewarding things in medicine to have somebody who has sleep apnea. If you treat it appropriately and effectively, and the CPAP works or surgical options work for them, it's really life-changing. And there's a dramatic improvement in people's lives who have sleep apnea once it's appropriately treated. They have a lot more energy, and it decreases their risk for some long-term complications associated with sleep apnea.
And that's why, like Dr. Davis and I keep talking about, keep trying it.
Yep.
Keep pushing that CPAP.
Right.
Work with your sleep medicine doctor to see if you can get it to work. This can make all the difference in the world.
Well, continuing with our ENT topics, a caller asks about chronic ear running after an acoustic neuroma resection and removal of part of the hearing nerve. Can anything be done to fix this?
You want me to? Okay. So that's referring to a very, very complicated, specific situation. Acoustic neuroma involves a benign tumor that's growing on the nerve between the ear and the brain. So an individual who's gone through that operative procedure has gone through a really complicated surgery. They've had a significant amount of surgery done on the ear. It's changed it quite drastically. So if we're seeing drainage, we want to know what's the nature of that drainage. Often drainage can represent infection, and we got to treat the infection. Rarely drainage after that kind of operation can be what's called CSF, cerebrospinal fluid. We'd want to know that too. So he should get evaluated. He or she should get evaluated, and there's probably his treatment.
Very good. Dr. Harden, is there a relationship between sleep apnea and the arrhythmia atrial fibrillation?
Absolutely. You want to treat sleep apnea on one part to improve people's symptoms during the day, but more importantly probably you want to treat sleep apnea because untreated sleep apnea increases risk for something called pulmonary hypertension, which is a cardiac problem, and it also, untreated sleep apnea definitely increases the risk of cardiac arrhythmias, probably most commonly atrial fibrillation, and it also increases your risk for stroke, and there's been some association with untreated sleep apnea and dementia, actually.
Thank you. Dr. Davis, what could be the cause of periodic, sharp, spasmodic ear pain?
There could be a number of causes for it. It could be actually ear itself, where you have ear infection or some type of actual primary ear problem, but it could also be related to the jaw joint too, which is just sitting right in front of the ear, which is a very common reason why people do get ear pain when they have temporomandibular joint disorder, which is usually a muscular issue or an actual issue with the jaw joint itself.
Dr. Harden, what are the side effects of fluticasone for treating eustachian tube dysfunction?
Fluticasone, I think, is it's a nasal steroid. So I think a steroid decreases inflammation. So if somebody uses fluticasone for a short period of time to treat eustachian tube dysfunction, it's pretty effective, and I prescribe it regularly. If somebody uses fluticasone chronically for months or years, it can decrease the thickness of the lining in the sinuses, and it can increase the likelihood that somebody's going to have a chronic runny nose from that. So generally what I do is recommend people, if they're going to use a nasal steroid that they use for eustachian tube dysfunction, they use it just when they need it for short periods of time.
Dr. Rhodes, this
Yeah.
caller wants to know regarding permission or eligibility for an MRI. The patient has had metal stapes implant. Can they still get an MRI?
The answer is, it depends exactly what kind of what we call prosthesis, but the vast majority of those prostheses are compatible with an MRI machine. Most of them are titanium, they're non-ferrous metals, so the vast majority can go through MRIs.
Okay, thank you. Here's a caller who's been admitted through the ER with vertigo, still having bouts of poor balance. Dr. Harden, could this be related to the history of vertigo a year earlier?
So if somebody had vertigo a year ago, and then they had an asymptomatic period, and then they developed vertigo again, it's probably something called BPPV, which is benign positional paroxysmal vertigo, which is a temporary disorder in the balance center in the inner ear that can cause really profound sensation of spinning, nausea, which patients will commonly describe this sensation of spinning as a dizziness. There's medications that can be used to treat it, but I would say if somebody had an episode of vertigo years ago and then or a year ago in a period of where they didn't have any symptoms and then they developed again, I'd say it's a recurrence of benign positional vertigo.
Thank you. This question is about ringing in the ears. Dr. Davis, what are some evaluations or treatments of ringing in the ears?
It's probably one of the most common problems we see as ENTs. It's called tinnitus, is the medical term for it. It's usually, not always, but the vast majority of cases are related to hearing loss. So it's kind of a symptom of hearing loss. And I always tell patients it's kind of the brain's interpretation of the hearing loss. So in terms of evaluations, everyone should get a hearing test to determine whether or not there's actually true hearing loss or not, and what that degree of hearing loss is. And treatments are tough. You know, if you Google treatments of tinnitus, you'll see lots of different things. A lot of it's not necessarily FDA approved or recommended, but the best way I find people to treat it is use background noise. So have some type of white noise in the background, or else have the radio on the background or something like that. Otherwise, hearing aids. There's a tinnitus mode on hearing aids if you're a hearing aid candidate, and that'll help bring down the ringing.
Interesting. Dr. Harden, what are some common risk factors for sleep apnea, and does weight loss help?
So for obstructive sleep apnea, some risk factors are being overweight and having large tonsils, and definitely, lifestyle changes which can lead to weight loss can sometimes effectively treat sleep apnea. So weight loss can decrease your symptoms of sleep apnea. But generally, if somebody has diagnosed sleep apnea, I would like to treat it with CPAP while they're losing weight, because I think treating their sleep apnea, giving them more time, more energy during the day is going to allow them to be more active and lose that weight. So weight loss definitely helps to treat sleep apnea.
Dr. Rhodes, what's the relationship between nasal polyps and sinusitis?
So nasal polyps refer very specifically to a structure in the nose where you develop basically look like very congested, engorged mucosa. And it's actually something that's genetic. Just some people have it. And it really has surprisingly little relationship to sinusitis, other than if you do an x-ray of them, their sinuses are full, but what there are is full of polyps, and many of those patients actually don't have infections. They just have polyps, and polyps in themselves will cause pretty drastic symptoms, so, but not always related to infection.
Okay, thank you for that. And Dr. Harden, caller wants to know, is the CPAP noisy?
The newer equipment is less noisy. I actually have a friend who has CPAP, and I didn't even know he was using it. And so the older equipment tends to be noisier, but the new CPAP equipment is almost noiseless.
Okay. And Dr. Davis, patient has a deviated septum and uses a CPAP. Is a surgery needed?
Only if you're having problems with the CPAP. So some patients, if their septum is deviated enough, it makes it difficult or uncomfortable to have the pressure from the CPAP to go through the nose. So in those patients, we can do strain the septum to make the CPAP more functional for them. But if you're tolerating your CPAP okay, without any issues, it's okay to have a deviated septum and use your CPAP.
Dr. Harden, this question is about how to manage oral lichen planus.
Oral lichen planus just, I think, needs to be monitored. You know, it's typically asymptomatic, but I think it needs to be monitored to make sure that it doesn't become a like a cancerous lesion or something like that.
Okay, thank you. And here's a question. A caller is sneezing about 20 times a day with no known allergies or colds. How might you begin that evaluation? Dr. Rhodes?
So sneezing usually is caused by some form of irritation in the nose. You sneeze because something is triggering the nose. Even though they may not have allergies based on testing, they're still reacting to something. So I usually would treat them with good, what we call nasal hygiene, meaning keeping your nose nice and clear. Saline is great, either saline spray or saline irrigations. Use of a nasal steroid spray will often decrease some of that inflammation that might be triggering the sneezing.
Dr. Davis, regarding nosebleeds, can you describe the indication for something called packing the nose?
So we try not to pack the nose unless we really have to. So probably the main patient you see coming into the clinic who has their nose packed either by the emergency room or the family medicine doctor is usually somebody who's had a significant nosebleed, and usually they're on blood thinners. Now sometimes patients who, you know, whether there's a trauma or they have a significant nosebleed, they get packed. We try to get those packs out usually in the first 3 to 5 days. And then after the pack comes out, really good nasal hygiene with lots of humidification and saline rinses to kind of prevent the reason why they had the nosebleed in the first place.
Dr. Rhodes, can you provide some thoughts on comparing the nerve stimulator procedure or treatment versus CPAP?
So the nerve stimulator treatment, we're talking about this device called the hypoglossal nerve stimulator. It's a relatively recent treatment. It's working really well. Dr. Davis and I are both placing them in patients, but it's an operation. We're surgeons, we like to do operations, but every operation is going to carry with it potential for problems or complications, we call them. So if you can avoid having an operation, you should always avoid having an operation. So again, CPAP should be your primary goal. As Dr. Davis said, up to 50% of people can't use their CPAP though, so for certain of those patients, the nerve stimulator is a really nice alternative.
Okay, Dr. Harden, a brief question from Superior. Does sleep apnea have an effect on blood pressure?
Definitely. Untreated sleep apnea causes high blood pressure. In fact, a lot of times people who have sleep apnea are identified because we try to treat their blood pressure with medicines and they're ineffective.
And Dr. Davis, a brief question. Can the tubes that a patient had years ago in their ears impact their health later on?
No, I mean, as long as they're not, they can be there for life and not have any significant impact. If you need to have your ENT check them out, if they are causing you some pain or some discomfort, but they can stay there for life.
Well, thank you for this very interesting question and answer with a very active audience tonight. I want to thank our panelists, Dr. Andrew Davis, Dr. Ryan Hardin, and Dr. Mark Rhodes, and our medical student volunteers, Anna Schuh, Tanner Nordseth, and Lucas Rodermacher. Please join Dr. Mary Owen next week for a program on lower GI problems when her panelists will be Dr. Joe Bianco, Dr. Jonathan Gapp, and Dr. Paul Sanford. Thank you for watching. Good night.